is provide you the facts of medical practice of abortion and answer questions that you might have. So I'm going to digress for just a moment. I don't know why that blue line keeps coming through there.
Interesting.
Isn't that weird? Okay. So I'm going to digress for just a moment and tell you about an experience I had when I was early in my practice. This would have been the late 80s. I went to a family medicine conference in Washington, D.C. The weather was wonderful, and at lunchtime, a group of women, we took our box lunches and we went out to just talk. And one of the topics that came up was abortion. And these were all physicians who were older and more experienced than I was, and they talked about when abortion was illegal. And women would plan their abortion for Friday nights because they would get paid on Friday night. And they would have an abortion, and these physicians said they could count on seeing several women in their ER the next night who had infections in their uterus. I almost directed. Okay, so they knew they would come in and they would have infections in their uterus because they had illegal and unsafe abortions. And I look at that, and I never practiced when abortion was illegal. And I knew that I could refer my patients to an abortion provider, and it was usually Dr. Tiller, who would take care of my patients. And if I had any problem, I could call him and he would tell me what we needed to do or offer to see the patient. And that didn't come up much, but he was accessible and I had confidence in him. What a difference it is. I never thought we would see abortion be illegal in this country again, and yet here we are. Margaret, would you like to talk a little bit about your background?
Sure. I was born and raised in Kansas. I lived in Lawrence and went to KU for my undergrad. For medical school, I did 2 years in Kansas City, my last 2 here in Wichita, and did my OBGYN residency. The only time that I wasn't Kansas trained was when I did my fellowship in maternal-fetal medicine, which is high-risk obstetrics, and that was in New York City at Mount Sinai. That was an interesting change, and I enjoyed it. And Barb and I know each other from med school, so we got to talking, and this is how all this came up after Barb invited me to potentially have this talk.
I'm thrilled to have her here because, again, she has experience that I did not have. My experiences in abortion was, taking care of my pregnant patients, but when they came into me and they were unhappy, it was unplanned, they wanted to know about their options, I would counsel them about all of their options and make a referral if that's the decision that they made. We're going to start with this, which I think you'll recognize as part of that presidential debate. We'll just do a little bit of it, but I want you to hear it.
I support Roe v. Wade, which had 3 trimesters. First time is between the woman and the doctor. Second time is between the doctor and an extreme situation. The third time is between the doctor, between the woman and the state. The idea that the politicians, that the founders wanted the politicians to be the ones making decisions about women's health is ridiculous. That's the last. No politician should make that decision. A doctor should be making those decisions. That's how it should be run. That's what you're going to do. And if I'm elected, I'm going to restore Roe v. Wade.
So that means he can take the life of the baby in the 9th month and even after birth, because some states, Democrat run, take it after birth. Again, the former governor of Virginia. Put the baby down, then we decide what to do with it. So he's willing to, as we say, rip the baby out of the womb in the 9th month and kill the baby. Nobody wants that to happen, Democrat or Republican. Nobody wants it to happen.
That is simply not true. That Roe v. Wade.
Well, that's enough of that. President Biden did a faltering job of trying to defend Roe v. Wade, but then Donald Trump came back with very inflammatory rhetoric, which was not true and doesn't help our conversations in our society at all. So I'm going to go on to
Wait.
Whoa. just a background of just normal pregnancies. There's 3 stages of pregnancies. Doctors look at it as 3 time frames. The first, a term pregnancy is 37 to 40 weeks when we consider a baby due. The first trimester is up to 13 weeks. Second trimester is 14 to 27 weeks. And the third trimester is 28 weeks to term. So when is a fetus viable? When could it survive outside the womb? Well, you're going to have to wait because Dr. O'Hara is going to talk about that in a little bit because it is not a bright line, okay? That's what I want to tell you, and she's going to go into more detail. So what can happen in the first trimester? Miscarriages usually occur, most of them, in the first trimester. The medical term for a miscarriage is a spontaneous abortion. We know that about 10% of recognized pregnancies end in a miscarriage. There's probably more than that are not recognized. Maybe the patient thought, oh, I had a late period and it was heavier than usual. And there's debate and studies done to try to figure out, well, how many actually do miscarry and we don't recognize it? And it varies up to almost 50%, which is a surprising statistic. But anyway, so miscarriages, they're sad. We support the patient. We try to educate her about what's happening, why it might be happening.
I'm sorry. That's just my blood sugar.
Oh. So we counsel them, tell them what to expect, what's normal, what's not normal. We can get them through it just by watching, waiting and watching. And most of them will complete on their own without us intervening. If we need to, there's a drug called misoprostol that can help complete it, or even a procedure, a vacuum extraction, where a small cannula is put into the uterus and the products of conception can be suctioned out. Now the other main concern is ectopic pregnancies. That's when the uterus, the pregnancy hasn't implanted in the uterine cavity, but it's up in the fallopian tubes, or it's on the ovary, or it's even outside of the uterus. That's a very dangerous situation because if that embryo is inside that tube and it continues to grow, it will rupture the tube, it'll hemorrhage inside their abdomen. That's a potentially fatal complication. So that's a situation we don't just sit and wait. We have to figure out what's going on, is that what it is, and figure out what to do for it, which would be either surgery or a drug called methotrexate can stop the growth and it will resolve. But this is a very dangerous situation potentially. In the second trimester, you can still get some miscarriages. Sometimes the embryo stops developing and dies, or the membranes can rupture early. The water around the baby, the membranes, protect the baby from infection. It's not supposed to break until they're in labor. If it breaks early, then bacteria that are in the uterus and the vagina can come up and get in there and cause infection, and it can even go into the bloodstream, what we call sepsis. Those are potentially dangerous situations also. So delivery is important to decrease those risk of complications, and doctors know that, and there's a protocol for when do you interrupt, when do you intervene in this stuff. So surgery or medical induction of labor, and again, Dr. O'Hara is going to go through some more of that. Third trimester, same thing. Also, the placenta is not supposed to come out until after the baby's delivered. That delivers oxygen and blood flow to the baby. If it separates early, that can cause hemorrhage. That can lead to a death of a patient. You've got to do something immediately. You can't just sit and watch. In the second and third trimester, or when fetal anomalies might be identified by sonogram, those are usually done 18 to 20 weeks or so when more things have developed and they can assess how the baby's developing. Chromosomal abnormalities are also identified in the second and third trimesters. You can do prenatal testing starting about 10 weeks by blood and understand if there's a chromosomal problem. But that's just a screening test, and you have to do more tests to figure out, is that really what's happening, or is that a false positive? You know, that makes sense? So what are our abortion options in the first trimester? The easiest and the most effective regimen right now is a two medicine regimen. A drug called mifepristone, which is given orally, and then 24 to 48 hours, a drug called misoprostol, which is just inserted in the mouth. It's absorbed in the cheeks. It's 95 to 98% effective in pregnancies up to 10 weeks. If mifepristone is not available, then misoprostol alone can be given in different ways, and it's 85% effective up to 7 weeks. Whoa, we're going backwards just a minute. So, misoprostol is a drug that's been around a long time and used for a number of different reasons, including the first time I was ever using it was to protect the stomach from ulcers. So it has a good safety record. Mifepristone was approved by the U.S. FDA in 2000 to use with misoprostol for abortions up to 7 weeks. Now, when a drug is approved by the FDA, they continue doing studies and monitoring to see, is it effective, is it safe? And after this monitoring, it was approved in 2017 to use up to 10 weeks. In some countries, it is approved for up to 14 weeks. So it really has made a difference, because in 2017, only 39% of abortions were done using medications. In 2023, which is the last dates I could find, 63% are done by medication. In some countries, in the Nordic countries particularly, it's being used up to 90% of the time. So that's a real game changer that way. Now, almost half of the abortions, these are United States statistics, occur in the first 6 weeks of a pregnancy. That big pink area is 6 or less weeks. Then the next blue area is 7 to 9 weeks. And as you can see, as it gets further along, it gets smaller and smaller until at 21 weeks or greater, the tiniest amount, that's less than 1% of abortions. So again, what Donald Trump was saying is absolutely ridiculous. Now, what are abortion options in the second trimester? Because the embryo, the fetus has gotten bigger, it requires procedures. And again, I'm going to let Dr. O'Hara talk about that more. So why aren't all of these abortions in the first trimester? Well, when does she discover that she's pregnant? Some people don't recognize it right away. They may have fear and anxiety about talking to their partner, talking to their parents about an abortion. The state may have already banned or have limited access for abortions. Funding, transportation, childcare, those are all things they may need to think about and take into account if they're going to have an abortion. And then it may be that the medical issue wasn't discovered in the first trimester. That's pretty common. And now, Dr. O'Hara, and if you'll excuse me, I'm going to have to change to her presentation. The first thing you're going to notice is she has many more colorful slides. Look at this.
Thank you again for inviting me. And if you have any questions during this, just ask.
Yeah, sure.
To be that young and thin. But the sign they're holding up isn't really true. You don't always have a choice. It depends on what state you live in, if you're willing to go across state lines to obtain an abortion, that kind of thing. So, like I said, we'll talk about abortion care after 21 weeks. This is me on my soapbox. I have to do something. And actually, I could play what President Biden said about terminations. It's maddening to me because Dr. Coates and I took a Hippocratic oath when we graduated from medical school not to do any harm. And unfortunately, complications in the first, second, third trimester may mean to save the woman from severe complications and to save her life, you may need to terminate the pregnancy. And that may not, depends on what state you live in, whether you have access to that or not. So I will leave the final wording of it to someone who's much smarter than I am, much more eloquent. And the state controlling a woman's body would mean denying her full autonomy and ultimately full equality. And that is my view on this. So you know where I'm coming from. So what are we going to talk about today? We're going to talk about what is late-term abortion, when is viability of the baby, and I will go over what Dr. Coates had talked about on why women may recognize a pregnancy later than the first trimester and give some examples of that. Late-term abortion typically refers to an abortion carried out after 21 weeks, but it's a non-medical term. So that's why I put it with the fake news. It's non-medical. ACOG, which you'll hear more about ACOG, it's the American College of Obstetricians and Gynecologists, and other medical organizations don't even use the term because it's inaccurate. Why is it inaccurate? Because to be stated accurately, you'd say what gestational age pregnancy was terminated, not just late term, because, and it also can be misleading from, again, that great clip that Dr. Coates showed about Trump saying about that's infanticide, that is illegal. When they put it as late term, it would suggest that you could terminate a pregnancy close to the due date. So viability is when, like I said, a baby with resuscitation and all the medical knowledge that the newborn intensive care unit physicians and nurses have helped to keep the baby alive, when can it survive? And there's two different aspects of viability. One is in the first or second trimester, and any of you who've had kids may have had bleeding in the first trimester. Oh my God, have I miscarried? You go in, you get an ultrasound, you can see the fetus is just fine. So that's viability under that circumstance. What we're going to be talking about is when the baby could survive after delivery. And viability isn't a term used much anymore, surprisingly. The American Academy of Pediatrics and ACOG, American College of OB-GYN, put the threshold of viability at 23 weeks years ago. But they were pushing the limits of that to see if even earlier babies could survive by providing them the same care that you would for 23 weeks. So the definition is what the term used now is a peri-viable period. And what is that? It's between 20 weeks and 0 days and 25 and 6. And several medical organizations have come out to support this decision. The National Institute of Child Health and Human Development, Society for MFM, ACOG, and the perinatal pediatricians of the American Academy of Pediatrics. Why they did this is to see when is it futile to intervene, and when you do everything you can for the baby and still can't survive even though it's normally grown, has no birth defects, has no chromosomal abnormalities, that kind of thing. So this is data from the Vermont Oxford Network. It's a huge database from multi-institutions here in the United States and across the world. And they collect data to see what works, what doesn't, and what they can use to help keep these babies alive and do their best. So we're going to go over gestational age, survival rates, and major handicaps. Can you all see that okay back there? Okay, great. Major handicaps, oh, there's a lot of them, but the most common ones that you hear are cerebral palsy, blindness, deafness, severe mental and developmental delays. So at 22 weeks, the survival, just for 22, I've seen other ones where the survival is less, like 8 or 9%, but that was all abortions performed prior to 23 weeks. It didn't use just the 22 weeks. So about 25% will survive, but I haven't been able to find any data on major handicaps. But you can get an idea of what it might be by looking at 23 weeks, just a week later, and look at this. Doubles the survival rate. But sadly, 9 out of 10 will have a major handicap that will change the dynamics, or can change the dynamics of a family life when the baby comes home, grows up, needs super extra medical care to help it survive, that kind of thing. But of course, not all of them do. At 24 weeks, the survival rate goes up to 71%, with about 70%, so a decrease of 20% of major handicaps, which is, that week. Isn't that amazing how much it can help? And then at 25 weeks, even though the survival goes up to almost 100%, half will have a major developmental problem. So perinatal viability, they use that so you can talk to a patient. And actually, when I used to do deliveries, which was more than 15 years ago, now I just do consultation, we would go in and talk to them and then have the newborn intensive care unit come in and say, this is, we gave them the preliminary information. They went in more detail about what they can expect. Now, obviously, you can't tell what's going to happen to an individual child, but what you do is an average of those that survive. Oops, didn't want to do that. And there's a whole lot of factors that can affect viability. One is gender. And here's one of my ultrasound slides. Black stuff is fluid. This little bubble-looking thing is the umbilical cord with one vein and 2 little arteries. And nothing looks like this: scrotum and penis. So a male fetus, unfortunately, doesn't survive as well as a female fetus. We're just tough. Little girl babies are just tougher in the neonatal period. I don't know why, but that's just facts. And then, what size is a baby? Is it normally grown? Is it small for the size for that stage of pregnancy? And these pictures, the 2 top ones are measurements of the baby's head. This bottom left one is measurement of the baby's abdomen, and the femur thigh bone is measured to give the estimated fetal weight of the baby. And if the baby doesn't weigh at least 500 to 600 grams, it's difficult for those children to survive. And also, there can be severe structural birth defects. If they have a horrible heart defect, they might not be able to survive because of that. And when you have one major birth defect, oftentimes, not always, but oftentimes there's others too that you have to consider. And with this baby, this is the chromosomes of a baby. And normally, we all have 46 chromosomes, 23 from mom, 23 from dad, that come together in pairs. And they're numbered from 1 to 22. That gives us 44. And the sex chromosomes, we have 2 sex chromosomes, that gives us a full complement of 46. On this one, as you can tell by the illustrative circle here, instead of having a pair, there's 1 extra chromosome of chromosome 13. That's called tri for the 3, trisomy 13, which is abnormal. Now, Down syndrome, we won't talk much about Downs because unless they would have a severe heart defect and other major birth defects, most of the women I have seen don't terminate a Downs baby. Some do, but most don't. But trisomy 13, and we'll talk about trisomy 18, that's 3 chromosomes of 18, have much worse prognosis than a Downs child. They're very developmentally delayed. They usually have severe birth defects, and it's not a good outcome, generally speaking. And then you have to worry about, well, what happened before the woman got to the hospital? Was she bleeding, like Margaret was talking about? Could she be abrupting? Did she have a fever? Could she have an infection inside her uterus? Did she come in just because she was having some contractions and was worried about preterm labor? And then during her stay, there's some things we can give the mother to help the baby, like steroids to help the baby's lung mature faster. Because that's been shown to help save babies' lives and to decrease the amount of oxygen and how long they're on oxygen, that kind of thing. And then a solution that nobody likes to get, but it helps the baby, it's called magnesium sulfate. Usually makes women nauseated, not feel good at all, but it's important to give it prior to 31 weeks because that'll help decrease the risk of cerebral palsy. So, did they get the steroids? Did they get the neuroprotection? Because that can make a difference on viability. And finally, we're so lucky at Wesley to have the newborn intensive care unit, because these people are angels who walk the earth, in my opinion. Because they, I don't mean to get emotional, they do such amazing work with babies. And if you have a gestational age of, let's see, somebody wanted to do it 21 weeks, and I had full resuscitation at 21 weeks. They would come in and tell them the dire prognosis for that hardly anybody survives. Any of those babies survives with a 99 to 100% severe developmental problem. But when you have them in the hospital, the baby's born with, and they can be attended to people who are savvy about of what to do for these early babies. Those babies have a much better outcome than if, let's say, you're in a rural hospital and you don't have all those resources. You don't have a maternal-fetal medicine doctor. You don't have a newborn intensive care unit doctor. If they deliver out there, then transport the patient into Wesley or any other tertiary hospital, they do worse because there's stress to the transfer of the baby. So they like to have the mother in the hospital where they have personnel that can take care of that gestational age baby. I keep doing that. So abortions after 21 weeks. First of all, like this white peacock, they're very rare, and like Dr. Coates already alluded to, it's less than 1% of all abortions provided, so it's rare. Is it safe? The mortality rate for abortions performed after 21 weeks is 8.9 out of 100,000. This is in contrast to abortions performed in the first trimester have a 0.46 mortality rate out of 100,000 live births. So the mortality rate for abortion care does go up with gestational age. When you compare it with the risk of mortality whenever we get pregnant, or which was as far in the past for me, we take our lives in our own hands, and usually we're glad to take that risk because ultimately the chance for dying from childbirth is rare, but still there. And the only one of the good news that I can tell you is the mortality rate for women decreased from a higher rate of 2022 at 22.3, now it's down to 18.6. So hopefully we can continue following that trend down of maternal mortality with deliveries. So even if you get an abortion after 21 weeks, it's still twice as, so the mortality rate is twice as likely if you give birth at time of delivery. Does that make sense?
Twice as safe.
Twice as, yeah, that's a better way of saying it. Thanks, Barb. How are they performed? Well, it depends on the experience of the clinician, what their comfort level is. what do they have all the resources to do all the different types of well, there's two basic types of terminations of pregnancy after 21 weeks. And what is the stage of pregnancy? Before you do a dilatation extraction, that's what D&E stands for, or when you do an intracardiac injection of the baby's heart to stop the heartbeat and then deliver, you always need to prepare the cervix. And you can use that with misoprostol. What that does is help dilate and thin out the cervix. Laminaria, we used to use in the old days, I don't know if they use it anymore, but the laminaria is made of seaweed, and it absorbs the vaginal secretions to make it to make it expand, and it forcefully expands the cervix with that. Now they're more likely to use a Foley balloon, and the Foley catheter that you put in your bladder, the balloon, you inflate that in the cervix, and then by the time the cervix is dilated so it comes out, the woman's usually 3 to 4 centimeters dilated. A D&E is, I'll tell you, it's some people find it very gruesome to think about, but how you do it is first you prepare the cervix so you can remove the baby safely without trauma to the mom. Then you aspirate the amniotic fluid so the fetus is there, and then you remove the fetus with forceps. So obviously dismemberment of the baby is going to occur. This may not be a procedure you'd want to consider if you wanted to do an autopsy of the baby afterwards. You couldn't figure out what was going on, but it was bad. And I've had some women, even though it's the safest way to perform a late-term abortion, or I used it myself, abortion performed later in pregnancy up to 26 to 28 weeks, some women don't like to do it because they don't like the idea of the process. And it's limited by how far along the baby is. Women or physicians who, all I know are women who do this, but physicians who perform abortions usually don't do it D&Es after 26 to 28 weeks. Why that is, the baby gets so large, the fetus is so large, and the bones get so calcified. And the hardest thing to get out of, obviously, is the largest part of the baby, which is the baby's head and skull. And you just can't remove the fetus safely after 26 to 28 weeks because it caused trauma to the mom. So if you can't do a D&E, we do, or how we did it in Sinai. I haven't done this since I've been back to Wichita, but we used an ultrasound, women who are going to have a termination pregnancy and then induce labor, use an ultrasound to find the baby's heart, and then use that ultrasound to direct the needle into the baby's heart and inject potassium chloride, and that stops the baby's heart. So then the induction of labor, and then obviously the baby's delivered as a stillborn. Now this isn't used universally throughout all institutions. I talked to a woman that I know who completed her fellowship in complex family planning, which is advanced abortion care. And I asked her, do they always do the intracardiac injection? And like I said, that's variable, but a lot of people do. So here we've gone through how they do it. It doesn't sound pleasant at all. Why would anybody think about getting an abortion during peri-viability or after? Well, one, a diagnosis is received later in pregnancy that might have a profound impact on the pregnancy's prognosis. And I have so many examples of this particular one, but that we've come across it, not frequently, but often enough that we have a lot, or I should say several, a moderate amount of people who've gone through this. A 28-year-old presented to our office because she had an ultrasound like Dr. Coates was talking about, at 20 weeks, usually around 20 weeks, you get an ultrasound for anatomy to see if there's make sure everything's developing normally. This woman had severe birth defects, and although she didn't get the blood test that Dr. Coates was talking about, what we call the cell-free fetal DNA, cell-free because the DNA from the baby's placenta floats around in the mom's circulation, so you can get a screening blood test by drawing some fluid, and they can tell you what your risk is for having a baby with trisomy 13, 18, 21, or Downs, and if it's a male or a female. It's a screening test, it's not a diagnostic test. So this woman, after her 20 weeks, she hadn't gotten a cell-free fetal DNA, and then she got one, and it was high risk for trisomy 18. Because the cell-free fetal DNA is a screening test, we don't do anything irrevocable until we have a diagnostic answer, and that's by amniocentesis. And sadly, the amnio confirmed the diagnosis. So, like I was speaking about before, I've had plenty of women with trisomy 18 babies. Sometimes they go ahead and deliver the baby at term. Some women want to terminate the pregnancy. And why would you want to terminate or think about terminating a pregnancy that had trisomy 18? The survival of the infant with trisomy 18 can be impacted by the severe birth defects. A lot of the trisomy 18 babies have bad heart defects, and that is probably the primary thing that limits the chance for survival. But a little over half, up to 75% survive for a week, up to 40% survive for a month, and then 10% survive beyond a year. And assuming that it is a full trisomy 18 baby, they would have to have, or almost all would have to have, continuous medical support. They're severely developmentally delayed. Like I said, if they saw, like they want to get a drink of water, they don't have the coordination to pick up the glass and take a drink. They can't speak. It's not, obviously not close to raising a normal child. Questions about that? Okay. Now this is when a mom is doing fine at the beginning of the pregnancy, and then all of a sudden something happens in pregnancy and the prognosis changes for her. And this is what I present this one because it's so weird. And unfortunately, when you hear these people spout or talk about terminations of pregnancy and why would you want such a late late termination, they don't know all the weird stuff that can happen. Because a lot of it's rare. So we had a 38-year-old woman presented for a fetus with a suspected sacrococcygeal teratoma at 21 weeks, and we diagnosed her with Mirror syndrome. And what is all that? Here's another ultrasound. Remember, the black is fluid. The sacrococcygeal teratoma, the CST, is all this part, and it develops on the coccyx or tailbone of the baby. It can be exophytic or be outside the baby, or endophytic inside the baby. And that is what a sacrococcygeal tumor is, and in real life, this is what it looks like. And then this is not my patient, this is one I took, but an example that I took from the internet. And I think this is just a beautiful resection and reapproximation of the suture lines of the baby with pretty good cosmetic effect. Not perfect, but pretty good. And the sacrogeal SCT is the most common congenital tumor babies are born with. When I say it's most common, it's 1 out of 10,000. So it doesn't happen all that often. Most are benign, but some can be malignant. And there's greater than a 90% survival rate. So that's good for a major defect. Now, why don't all those babies survive? There's some warning signs if they're rapidly growing, and for babies that have had SCT, we see them back every week, 2 weeks, 3 weeks, till we can figure out if the size of the SCT is stable or is it growing. If it gets really large and vascular, meaning tons of blood vessels go to this tumor, and it can overwhelm the baby's ability to perfuse or get oxygen to its vital organs. And when that happens, you get a condition called fetal hydrops. And fetal hydrops, the baby's circulation can't keep up with the needs of its cells because it's diverting so much blood to the sacrococcygeal teratoma because it has so much blood supply. So the cells that get shortchanged or don't get the oxygenation that it needs and nutrients, that kind of thing, they start malfunctioning and extrude the fluid into the outer compartments, wherever that might be. Like I said, black is fluid. So here is the baby's abdomen down here, collection of fluid called ascites. And here, the tiny little lungs of the baby. So therefore, with those small lungs, they wouldn't be able to oxygenate enough to keep it alive. And this fluid around the lungs are called pleural effusions. And if you have two abnormal fluid collections, that's fetal hydrops. And at least half the babies of fetal hydrops die before delivery. Now, there's some cases where you can resuscitate them inside the uterus, like giving them an intrauterine blood transfusion, but sadly this wasn't one of those. And all that swelling in the baby is mirrored in the mother by horrible edema, horrible swelling, as you can see by that foot. And then preeclampsia, as you know, is a high blood pressure disorder that occurs during pregnancy. Usually has high amount of protein in the urine because the kidneys are mildly damaged, and it can be mild or severe. Sadly, this woman and this one had severe preeclampsia by elevations of her blood pressures to such a degree, and she had elevated what we call liver enzymes, showing that there's been some harm to the liver. Why I bring that up is those women you can't wait and watch. So you have a decision to make. Here she is, a periviable period, 21 weeks. We don't have any. Now we can send a baby, if we find them early enough and they don't have hydrops, send them off to, we send them to Children's Hospital of Philadelphia or CHOP, and they can do fetal surgery by resecting the sacrococcygeal teratoma and then put the baby back inside the uterus, sew it up, and wait till delivery. But we didn't have that option then. So we couldn't resuscitate the baby enough to get it to a viable stage. The mom was too sick to get to a viable age. So what we did was we called the ethics committee, because at Wesley you cannot perform an abortion unless it's to save the mom's life. And so we went to the ethics committee, told them what was going on, and with severe preeclampsia like that, to keep her pregnant. It's more likely that the baby would die and that she would die. So the ethics committee gave us okay, and we delivered the baby. And the baby had comfort care, so you hold and love the baby till delivery, or till the baby passes. So that's what happened with that case. Yeah. This happens all the time. I had a woman, well, a young girl, when she was coming to the ER screaming, "There's no way I can be pregnant," when the head was coming out of the vagina. So denial is a very strong feeling. And also, you know, there's a lot of medical disorders like diabetes, thyroid problems, polycystic ovarian disease, where you miss periods and you don't even think, well, that's common for me, so I don't even think I'm pregnant, or women in their 40s thinking they're in menopause when, oh, it's oh my goodness, baby. And the good thing is, most of the time, because most babies are normal and they have a good outcome. The mom might have a healthy, did you have a question?
A comment. 16 years after I had a tubal ligation, and a fimbriectomy
Uh-huh.
to prevent a third pregnancy after I'd had a spontaneous abortion, and delivered one child with problems that were correctable.
Thank you.
Found myself pregnant, thought I had a uterine tumor because I knew I could not get pregnant. However, physician said, yes, you are, but let's get a sonogram.
Uh-huh.
Went to get the sonogram, confirmed a pregnancy, and I was days away from the third trimester, and the baby was not viable.
Oh, I'm so sorry.
And, but an OBGYN and Dr. Tiller went ahead and helped me get through that, because as a type 1 diabetic, since age 19, was another complication. What was wrong with the baby I never knew, other than it would not live outside the womb. And I didn't have enough thought at the time to even try to ask.
About that.
But had the procedure.
Perform. Yeah. Well, thank you for that. I'm sorry what happened to you, though.
We laugh, young girls say, no, I can't get pregnant, but when you've had surgery to prevent it, and then 16 years later, and of course my OBGYN who did the procedure was totally astonished as well, because it had only happened once when the woman was already pregnant, when he did the fimbriectomy. Yeah.
Oh, dear.
Anyway, I share that with you.
Thank you. But like about a third or 3% of babies will have birth defects. Half of them are severe, half of them are minor. So, like I said, most babies are normal, but you could find severe birth defects or birth defects, and like we talked about earlier, if there's one severe birth defect, there's a higher chance of having another one, and whether that can be compatible with life or not. And chromosomal abnormalities. Barriers to obtaining care early in pregnancy. Seems like the big one is money. And, oh, I didn't tell you, I'm a brand new board member of Trust Women. So, I trust women at least, and I don't know about others, but if you have a medication abortion like Dr. Coates was talking about, that's $750. If it is a procedural abortion, then that is $750 to $1,600. And then if it's a 2-day procedure where you have to prepare the cervix first and then do either the D&E or the induction of labor the next day, that's $1,800 to $2,400. And they do terminations up to 21 weeks and 6 days. It can be much more expensive if you go to clinics that do it past that gestational age. So they can be thousands of dollars. And it's hard to find people that will supply care anymore, because so many abortion clinics are closing because of state laws, because of a lot of different reasons. They may not be able to travel if they live in one of the southern states where they have abortion bans at 6 weeks. Work obligations and mommy duty. I mean, they all conspire against you on getting earlier care. And finally, it can be a combination of any of the above. So a woman who's facing this, I've never had to do it. I have 2 adopted kids, and one that I gave birth to that I wouldn't trade for anything. But if you find yourself in this horrible situation, think of all the hard decisions you have to make. Will my baby survive? If it does survive, will it be able, how will it survive? Will it be in what we call intact, meaning no major birth defects? And what about my safety? And can I afford it? I mean, there's just all of these things going on to make this a very difficult decision. And what really upsets me is when people talk about, oh, I just had an abortion. It's not like that. I don't know one woman that's like that. There may be,
I just don't know any. So anyway, the rest of it's Margaret. I'm sorry about that.
Well, you have added so much to this presentation. I really do thank you for agreeing to do this, because these are hard topics, and I agree. I never had a patient that I thought just was doing it just without thinking about it. It's a hard decision. So I'm going to go back to my boring stuff.
Untrue.
Let's see, get back in here. I'm going to go towards the legal side now. In 1972, the Supreme Court was asked basically, does the Constitution recognize a woman's right to terminate her pregnancy by abortion? And their opinion said yes, by a 7-2 decision. They used the Due Process Clause of the 14th Amendment as a fundamental right to privacy that protects a woman's right to have abortion, make that decision. However, they balanced that against the government's interest in protecting women's health and protecting the potentiality of human life, and that's there. Now, Roe v. Wade, they divided it into a framework of 3. In the first trimester, Roe v. Wade said the state cannot interfere with that woman's decision. In the second trimester, they can impose regulations that are reasonably related to maternal health. And in the third trimester, once it reaches viability, which has certainly changed definitions since 1972, the state could regulate or prohibit entirely as long as there are exceptions for the health and the life of the mother. The justice who wrote this primarily was Harry Blackmun, and he was considered a conservative justice when he came on the court. But before he was a judge and before he was a justice, he was the legal counsel for the Mayo Clinic. And it was thought that his exposure to the hospital medicine and the doctors may have influenced this framework, which I think made sense. So then we come to Dobbs versus Jackson. Now, although states could regulate for the maternal health, states were passing laws all the time trying to add things to it and interfere. And Mississippi had passed a law banning almost all abortions after 15 weeks. Well, that obviously contradicted Roe v. Wade. So lawsuit was filed and went to the Supreme Court, and as you know, in 2022, they ruled 6-3. The Constitution did not confer a right to abortion and overruled it. So the laws regulating abortion went back to the states. And we know what happened. So all the darker orange states are those that have restrictions. The darker the orange, the more restricted they are. And then the lighter shades have fewer restrictions. The blue states are states that have protection for abortion. The darker they are, the most protection, and lighter ones are less so. And then the striped ones have kind of a combination, restriction and protected. As you can see, most of the dark orange ones with the most restrictions are in the southeast. And you can tell geographically, Kansas gets a lot of patients from Oklahoma, eastern Texas, Arkansas, and Missouri. And you know what just happened with Missouri just a couple days ago? Now, even though the citizens passed a constitutional amendment protecting abortion, their legislators are fighting them, and a court has now let the ban go into effect again. So it's a fight. Last year, in Kansas, 70% of the abortions performed were done on people from other states. And our Kansas legislators don't like that. So how do the restrictions affect care? Going off in Margaret. If there's a complete ban, they may need to leave. If it's a ban after certain weeks, well, do they have the information to know if that's what they want to do? Do they have the resources to leave the state and get an abortion if they decide that? And it puts restrictions on the doctors too. They may be in this question of, is it legal to intervene in this pregnancy or not? And I was reading a story from Texas where they said doctors might call their legal person in the hospital and say, can I interfere? And they would either not answer or they would just read the law to them. And they're left in limbo. When can I intervene legally? And they can even fear that they could lose their medical license or even face criminal charges for performing an abortion. This is showing states that have even put in prison sentences if you cross their line. West Virginia, there's no prison sentence, but it ranges from 2 years to life in prison if they intervene and someone decides later it was not acceptable. There are also all sorts of what are called trap laws that legislatures have put in. Even though they're purported to be to protect the maternal safety, the safety of the woman, they're basically ways to obstruct abortions clinics. They can make structural requirements such as, well, you have to have the same equipment and size of the procedure rooms and stuff as an ambulatory surgical center. Well, that's not what is really, I mean, ambulatory surgical center has lots of different procedures done. Their procedure rooms need to be larger to accommodate more personnel and more equipment. That's not what's necessary in an abortion clinic, particularly if you're doing lots of medication abortions. They can also require the doctors to have admitting privileges to hospitals for complications. You know, doctors, to practice in the state, have to have licenses. They go through all the verification of their qualifications and such. But not all doctors have admitting privileges to hospitals. If they don't go to the hospital for what they do, they don't need that. But if they make that a requirement, then it just puts obstacles in the place for the clinic to get providers, and it delays when they can work. 24 states have track laws. We're one of them. Now, Kansas law right now, in 2019, our Kansas Supreme Court said that our Constitution and Bill of Rights protects a person's right to personal autonomy, and that includes abortion. As you know, in 2022, the legislators decided they would put a constitutional amendment on the ballot. It was called Value Them Both. What it would have done is to say, well, our Constitution does not infer the right to abortion, and regulation should come from the citizens of Kansas through their elected legislators. Well, guess who those are? They're the ones who are putting this on. So we knew that they could go even as far as a complete ban on abortion. Well, that was rejected by the citizens. So currently, it allows abortions up to 22 weeks and in cases where the mother's life is in danger. But our legislators passed a Women's Right to Know Act in 1997, and they continually make amendments to affect abortion law. So I'm showing you this. This is just part of it. And I can't read it on the screen, and you can't either, but it's to give you a sense of all the regulations that they can put in place that this abortion clinic and providers have to do and have to prove to the state that they've done, and on and on and on. So here's a few things that were included. That patients be given state-mandated information with unfounded medical statements, such as abortions increase breast cancer risk and premature birth in future pregnancies. This state-mandated information has to be in specific typeface, font size, and color, and given to the patient 24 hours before. Then, after they've met with the provider, they have to wait 30 minutes before they can have care. And they have to tell the patients at least 5 times that medication abortion can be reversed. Well, now, I mean, the abortion clinics and the legislature, they go back and forth with lawsuits. And there's a lawsuit involved in this, and a temporary injunction for these particular sections was granted in October of 2023. So, I titled this Fact versus Fallacy, so I'm going to go through some of this. It is a fallacy that abortion increases the risk of breast cancer. Women who have had abortions have no greater risk for breast cancer than women who have had abortions. Did I say that right? It's the same. Okay. It's a fallacy that there's poor long-term psychological outcomes in women who have had abortions. Long-term studies have not shown increased depression, anxiety, other psychiatric mental health issues than women who have not had abortions. It's a fallacy that abortion is more dangerous than childbirth. In the U.S. in 2023, as she said, the maternal mortality rate was 18.6 per 100,000 births. But in that 10-year period, it's only 0.45 deaths in 100,000 abortions, so less than 1 in 200,000 abortions. So it is not more dangerous than childbirth. It's a fallacy that abortions can affect future childbirth. First trimester abortions, there's no increase in infertility or miscarriages or premature births. It's a fallacy that medication abortions can be reversed. The thought behind that was that the first drug, mifepristone, obstructs progesterone, and that's necessary for the development and the growth of the baby. So they thought, well, what if a woman gets mifepristone and then changes her mind? Could we give her progesterone and reverse that? And they had to stop the study after just 12 patients because 3 of them hemorrhaged so badly, they had to go to the hospital in an ambulance. And they said, this is not safe to do, and we shouldn't be promoting it yet. That's not an uncommon thing that's being promoted by people who oppose abortion. It's a fallacy that emergency contraception pills like Plan B cause abortions. Contraception prevents or delays ovulation, the release of the egg. And if a person happened to be pregnant and didn't recognize it and took Plan B, it will not interfere with the establishment of a current pregnancy. Can interrupt it. It's a fallacy that IUDs cause abortions, intrauterine devices. Those are for contraception. There's 2 main kinds. Some secrete a hormone, which again, just like the birth control pill, stops the ovulation, prevents that. There's another one called copper, which secretes a little bit of copper, and it's primarily preventing fertilization by changing chemically the sperm and the egg before they meet. It is a fallacy that mifepristone is unsafe and should be taken off the market, and that is being pushed very hard.
Just a comment about the IUDs cause abortions. I saw a statistic recently that said that something like 30% of all physicians actually believe that. So I thought that was
Really?
shocking.
Well, when
Amazing.
in training, we were told that they primarily caused it by being in the uterus. It made the egg and the sperm think, oh, there's something already here, we'll go on out. Is that what you remember?
Uh-huh.
Okay, well, the theory has changed now as to how they work. So,
You might have to educate a physician.
well, things do change, you learn things, so, okay, but I think that's where that comes from. Mifepristone being unsafe to be taken off the market. That is being really promoted strongly now by abortion opponents. And that is not true. Even though it was only approved in 2000 in the US, it's been used in other countries since at least 1988. Almost 100 countries now use mifepristone. It's on the World Health Organization's list of essential medications. Millions of medication abortions have been done with this. And the risk of complications, and particularly any serious complications, is extremely, extremely low. It's a fallacy that there's a high rate of complications after abortions. A study came out that said 34% of the women that we collected in this data had to go to the emergency room within 30 days of their abortion. This was so out of line with all the other studies that the journal that printed it asked for an independent review from experts, and they looked at it and they were counting every visit to the ER for whatever reason as a complication of the abortion. And it turned out when they really dug into it, which was there only 1 to 2% were related to the abortion itself, and there were no serious complications. But that is being promoted. It's even, RFK Jr. said, this is important and we're going to study it. So God help us that he will read the people who reviewed it and not just the initial report, which, by the way, was done by an anti-abortion organization. And it's a fallacy, as you now know, that there are late-term and after-birth abortions. This is just not true. These are always tragic situations. So I was asked whether abortion laws can affect contraception. Well, some states do have explicit protections for contraception. The ACA at this point requires most private health insurance plans to cover contraception. Our House, the U.S. House, passed a Right to Contraception Act in 2022, but it was blocked in the Senate. Title 10 governs national family planning programs, and already the Trump administration in their budgets are trying to remove that funding or affect it. They tried in their first run of Trump to prevent family planning clinics from counseling about abortion, referring to abortion providers, and it's on target again. And then the South Carolina governor ordered their state to take Planned Parenthood clinics off the list of authorized Medicaid providers. Obviously, Planned Parenthood does much more than abortions. They do contraceptive care, they do STI testing, they do cancer screening, but that would eliminate people being able to go for those reasons too. There was a lawsuit, case went to the Supreme Court, and we are waiting to see what they're going to say. These are states that have legal protections. The blue ones have it in their laws. The green ones have it in their constitution. Personhood. I am getting to the end of this, but this is something abortion opponents are going to be pushing. Their belief is that every fertilized egg, even before implantation, should be treated as a person. If this is passed in a state, or even worse nationally, this has huge implications. Abortion bans, ban on IVF, criminal prosecutions, delayed cancer care during unwanted pregnancy. 1 in 1,000 women have cancer when they're pregnant, or develop cancer when they're pregnant. And those drugs that could treat the cancer could affect the baby. If a woman is using substances and is pregnant, she could be prosecuted.
Like what kind of substances?
Like cocaine, meth, anything like that. I mean, that's happened before.
Right.
District attorneys have tried to do that.
It's always failed before, hasn't it?
Well, we're
We'll
at different
see.
times.
Yeah, that's true.
Yeah. A woman could have a miscarriage and go to an emergency room and be accused of having had an abortion. It could restrict access to any drug to childbearing women because of potential fetal effects. There's drugs that are used that we know that. Accutane for acting has that. There's strict regulations about assuring that you're not pregnant and all that, which is good, that's good. But there's also methotrexate, which is used for cancer chemotherapy and rheumatoid arthritis. Could those women have it? It could affect research on new drugs. Would women of childbearing age be included in studies if there's a liability to the pharmaceutical company, if there's a birth defect determined? Okay, getting back closer to home. Our legislature passed, put on the ballot, the Senate Concurrent Resolution 1611. As I said, our Supreme Court said we have personal autonomy based on our Constitution and the Bill of Rights. Well, our legislature thought, well, we'll just change the people who are on that Supreme Court and they'll see it differently. So they would like to have the Supreme Court justices not selected by merit, as they've been done for 60 years, but to directly elect them, just like they did in Wisconsin. And they're pretty certain that if this passes, then they would be able to get who they want on the Supreme Court eventually. So this is on a primary ballot August 20, not this year, but next year. It's just like value in vote. We're gonna have to get people out to the primary, and they need to know to vote no. And that, long time there, but we appreciate your attention, and we will certainly answer questions, comments.
What are the chances that they will change the wording that will go on that ballot in 2026 so that we might be confused, but yes or no?
I don't think they can do that at this point. I think, isn't that decided? I'm gonna go to my legal.
I'm not sure, but yes, it's gotta be whatever the
The bill
resolution
was,
was,
yeah.
yeah.
And I believe it's,
It should be pretty
okay.
clear cut.
I think it
don't
was
know.
clear cut that it'll be a vote no. But that's always concern. I mean, they really did try to make it complicated. Yes, no?
A further question that I've always had a concern about, and that is whatever happened to the the privacy between a person and their physician, and the access of the government to have knowledge about that at all.
Is that HIPAA?
I mean, that seems to have totally been forgotten about. So that consequently, if the law finds out I've had an abortion, then they think they can do something about that to my doctor for having that private conversation and decision with me.
I don't know.
I don't understand that.
I don't know. I know for doctors, it is still not legal. It's not, we don't talk about that. I mean, it's private. How they, you know, with Doge and all of their information stuff, when I hear that they're making data from medical records, I'm like, what the hell? You know, what are they getting? And we don't know.
Another question. I have a concern that there is so much emphasis on bringing a 16-cell, whatever the terminology would be, in a pregnancy to term and nurture and care for that, even at the risk of the mother, people willing to do that, when born children are denied food and allowed to die by the millions. And it's the same government allowing that to happen. Why are we not charging murder
Well, that's a question I can't answer, but I think we all agree with you.
to
that
politicians
it
who
doesn't
are
make
making
sense.
rules that we're taking food aid away from children in the United States? Child care, health care, every right under a known man, and we take it away from the born in order to save the unborn. I want somebody to really argue their case to convince me that the pro-life people, and I hate that term because I'm pro-life as well, and I've been faced with a variety of decisions to deny on
Mary.
I just want to share a story about our mothers, founding mothers from the American Revolution. I'm reading a book, Eliza Hamilton, the story of Alexander's wife, and I just finished the chapter where her best friend died in childbirth at the age of 36 after 12 pregnancies, only which 6 survived. And it goes on and on. I mean, how those courageous, in one instance, Eliza's mother and her 2 older sisters were all pregnant at the same time because they were all so young.
Yeah.
And the generals and the colonels would come home, the girls would be pregnant, the men would go off, and they were left to, birth their own. The sisters were holding each other's hands, and there was no pain relief except brandy from their father's cellar.
You know, when you read historical documents,
Oh,
childbirth, death from childbirth was not uncommon at all.
well, and then Eliza volunteered to raise the baby, Fanny, that survived the 12th pregnancy where the mother died, and her toddler sister. on top of her 3 children. Amazing stories with those women.
Mike?
I would just like to encourage everyone that we all work together to defeat that amendment in 26, but make sure people vote in the general election.
The
Because in
primary.
22, it did not happen, that people came out and
Oh,
voted
they
in
come-
November.
After.
Yeah, they voted in the primary, and then they thought, we did our job, we're done.
Well, that was then, this is now.
That's right.
We have
need
found
to
out that the
encourage people
job
to
is
stay
something that's
engaged.
gonna continue forever. There's never gonna be consensus on this. And I don't have it with me, but I read part of the opinion of Roe v. Wade. I mean, they made it so clear, this is such a complex situation. We all have different ideas, different beliefs based on religion, our own morality, so many factors, our experiences. We're never gonna have one consensus. And to me, I felt like Roe v. Wade tried to make it as palatable to everybody, but no.
One thing I'd like to add to what Dr. Coates was saying is I have had at least 10 women, maybe more, tell me that I am pro-life and I never thought I'd have an abortion, but I'm glad I'm able to have one. And
A safe one.
a safe
Yeah.
one, exactly.
Yeah.
I was just gonna say, I graduated from nursing school in 19